Hello and welcome back to the second part of our sort of webinar on remote clinical interventions. And what I'd like to do now is to welcome Bethan Phillips, who is from the Children, Young People's and Families faculty of the British Psychological Society. Bethan is actually speaking to us on the phone, and so thank you, Bethan, for bearing with us and speaking to your slides. If you just ask Rachel, she will move the slides on for you. Thank you. Goodbye. So do we have a further technical hitch? I can't hear Beth, and I'm hoping that others can.
I'm just waiting for the slides to start.
All right.
Okay.
Great.
Thank you.
Thank you.
Can I have the next slide, please? The COVID-19 pandemic has accelerated the implementation of the potential contribution of using video platforms for clinical work. As the committee that think about and work with children, young people and their families, we felt that it was important to have some specific guidance written to help people think through and prepare their practice. Next. On to the next slide, please. As a committee, we have a wide breadth of experience working with children and young people, and quickly became aware of specific issues for working with children and young people via video platforms that may differ from working with adults. Things to consider include the child's developmental requirements. Are they able to engage on a video platform? Making sure to explicitly consider any additional needs the child may have, including neurodevelopmental differences, sensory processing difficulties and learning difficulties, and making an informed judgment about whether video sessions are right for this child or young person. If going ahead with working via video, it's important to consider the goals of the work. Renegotiation may be required, as certain work may be more difficult. And think about how you'll work creatively. Often in sessions, children are up and down, moving around, playing with things, so it's important to think about how you can do this via a screen. Turn-taking games like Noughts and Crosses, Hangman and Pictionary can all be really helpful in continuing the creative work with young people. Next slide, please. It's important to have a set format for the sessions, and that the format is familiar to the child or young person if they are ongoing sessions, and they help develop familiarity for new clients. Ensure the young person can give consent and check this regularly through the session. For younger children, it's important to check in with parents and carers at the start of every session and is appropriate at the end also. For older teenagers, this may not be required, but will depend on your service context. Personally, it's something that I like to do, as I would have done that anyway in my face-to-face work. Ensure there is a discussion with a parent or carer to find out if there are any new issues with the child or family, especially any issues related to COVID-19. Next slide, please. When thinking about confidentiality and safety, there are a number of questions that as a committee we felt would be important to ask. Does the child feel safe? Who else is in the room? This is important because there may well be people in the room who you cannot see on screen. If there's no confidential space in the house, then consider how you'll adapt the psychological work to make the session safe. Ensure the video platform is used with a password and appropriate security is enabled. And remember that there may be increased demands on a child's attention, and they may be coping with distractions that are unseen by the present. Do they also understand that you're not in the room? They may see you on the screen with them, but it's important that they realise that you're not there with them. And finally, it's important to be clear with children and parents and carers that any safeguarding concerns will be managed in the usual way, and be mindful that video may reveal risks that maybe have been unknown before. Next slide, please. When thinking about contracting for the sessions, there are three main points that we felt were important. The location of the session. Firstly, for younger children, we recommend that sessions should not take place in the child's bedroom, but in a space in the home that can be made confidential. For teenagers, the bedroom may be more appropriate, but this should be by explicit agreement between the therapist and the family. And for older teenagers, it may be appropriate for sessions to take place outside of the family home, for example, whilst out taking permitted exercise, but again, this needs to be thought through carefully. Ensure that there's an agreement that the child or young person or the parents will not record any part of the session, and check there is adequate security around the system you are using. For example, things like password protection, locking the room, creating new meeting links for each meeting, clearing cookies, etc. In terms of the boundaries of the session, it's important to explain that the therapist will be convening the sessions. They invite the young person to attend, and video contact should take place through a parent or carer's account. Next slide, please. Thinking about how we support a child who becomes distressed. How will you manage this during a session? It's important to plan in advance with the parent or carer, including gaining an additional telephone number to be able to contact the parent or carer if there are IT issues. Check in regularly, and if you see the child or young person is becoming distressed, maybe change things. Cut the session short, bring in a parent or carer, or rearrange if possible. And if you have had a session where a child or young person has become distressed, it's important to follow this afterwards, possibly with a telephone call or email. Can I have the next slide, please? There are also some things that you need to consider as a therapist. If working from your own home, ensure that you have a required level of confidentiality. Think about the room you're using, what's on the wall behind you, and use things like headphones to reduce noise and increase the confidentiality. It's also important to ensure that supervision and team structures remain in place in relation to remote working. These may need to be developed in your workplace. And ensure that you have to check that your employer and professional insurer are happy to cover video working and that you are GDPR compliant. Next slide, please. When conducting psychological assessments by video, it's really important to remember that most tests are not standardised for video use. Assessments that can wait should wait, and any that cannot should be recorded with extreme caution. For assessments that cannot wait, including when there's family court involvement, ensure that relevant guidance is followed, and as above, interpret any assessments with extreme caution. Next slide, please. Maintain engagement when you can't work by video. What else can you do if using a video platform isn't going to be helpful for the child or young person? An initial session by telephone may be required to encourage early engagement. And think about other modes of communication, working by telephone, WhatsApp or text, email may be more suited for families, and there's always a therapeutic letter which can really help in these situations. For families where video working is not possible or desirable, then make a plan for how you'll keep in touch with the child, the young person and their parents and carers during this time. Next slide, please. You can read more about these guidelines on the BPS website as part of the DCP resources. There are also some really useful guidelines and documentation that we've developed around talking to children about illness, for children whose parents may be key workers, and also for parents themselves who are key workers and may be looking for guidance at this time. Thank you very much.
Thank you very much, Bethan. I know that's very difficult for you. You've had to sort of on the spot try and cope with a 20-second delay, and I think this sort of illustrates some of the challenges for all of us and for all of you in sort of working remotely with the challenges of the IT as well. But next I'd just like to introduce Banadka Dubika, who will talk from the perspective of the Royal College of Psychiatrists. Thank you, Banadka.
Hello, my name is Dr. Banadka Dubitska. I'm the chair of the faculty of the Child and Adolescent Psychiatry Department at the Royal College of Psychiatrists. I'm an honorary reader at the University of Manchester and also a consultant at Penline Care Foundation Trust. I've been asked to talk to you today about some of the guidance that the Royal College has produced about the coronavirus pandemic. We've been working very hard over these past few weeks to produce as much guidance as possible for clinicians and also for children, young people, families, and other patients. This is a fast-moving field. We're constantly updating our guidance, so do keep looking at our website to see what else is going up there. And we also have new guidance in development. We're aware that a lot of organisations have produced a lot of useful guidance, so we have tried to fill a particular space that will be relevant for our members. Here's a screenshot of some of our guidance for clinicians, just to give you an idea about the variety of information we do have up there. Amongst all the information we have, most importantly, we have information about wellbeing and support for clinicians, guidance on risk for BAME staff, ethical considerations, and also our psychiatrist support service, which is crucial at this time. I will mention some of the specific guidance we have around prescribing for children and young people for child and adolescent psychiatrists and other prescribers. This is guidance that we've just recently put up there. So first of all, I'll say a few words about the remote prescribing of psychotropics for children and young people. And we've put up some general principles that we'd like people to think about before prescribing. Firstly, and very importantly, we always have to think about individual circumstances, and particularly under these conditions. So we need to think about the severity of the disorder, how impaired the child is, and the level of risk that presents as to whether remote prescribing would be indicated. We always need to consider the evidence base for medication and also for psychological treatment options, and whether psychological treatment might be given prior to considering medication. And again, we always think about benefits and risk, but particularly within this pandemic, we need to think about the benefits and the risks of remote prescribing. And very importantly, we need to think about the consequences of not giving treatment and what harms that could do to the young person. In terms of adverse effects, we need to think about adverse effects of any intervention that we're giving, but particularly how we're going to manage that remotely during this pandemic. Supplying prescriptions has been challenging, and this will very much depend on your local area. Some areas ahead of the game already have e-prescribing, which will make this much easier. Other areas will have to think about whether families can pick up prescriptions. If they're not able to, in some areas it might be possible to have a relationship with your local general practitioner to help prescribe over this period. Physical monitoring is, of course, particularly challenging during this time, as we need to reduce physical contact as much as possible to reduce the risks of transmission to the virus, both to our healthcare staff and also to vulnerable families and children and young people. In some situations, for example, blood pressure and pulse monitoring, it is possible to work with families and trying to do this remotely. However, sometimes this isn't always possible, and certainly for some medications, blood tests may need to be considered, as well as heart tracing, which will require face-to-face contact, and again that will need to be thought about in terms of the overall risks and benefits of prescribing. And lastly, effective communication is important, as always, with all other professionals who are involved with the young person. And all these decisions must be taken collaboratively, both with the child, young person and with their families, in thinking about the risk benefits of prescribing. Moving on specifically to ADHD, because this is something that's seen very commonly within our services. and we've just put guidance up around this. This guidance has been done in conjunction with our child psychiatry colleagues working on the European guidance for ADHD, and the link for that can also be found on our website. So again, here's a few principles that should be considered. And firstly and importantly, we need to think that the condition itself, ADHD, may in itself lead to health risks leading to COVID infection, particularly due to the element of impulsivity that we see in children and young people, and that prescribing might actually reduce some of these health risks. So I've seen older adolescent boys, for example, who are very impulsive, who weren't taking the safety guidance from the government very seriously and were breaking social distancing rules, but on medication their behaviour did change quite dramatically. So it is important to think about medication treatment for that reason. Again, individual need needs to be considered. So I've also had families where medication has been particularly important in terms of attending school and education, and families have felt that during this time that medication hasn't been as essential as when young people go back to school. We should also endeavour to implement parent-based ADHD interventions remotely as much as possible, and also adhere to local national guidance as much as possible. And again, we appreciate that sometimes that can be challenging under the current circumstances. As I've already mentioned, we are asking parents and carers to assist with home physical monitoring if they're able. Often that is possible. However, accuracy does need to be assessed. Sometimes you might need to aid the family through a video consultation. For example, I had a reading recently from parents where the blood pressure and pulse was quite high of a child, and when I inquired what was happening at during those circumstances when they were taking this, it turned out the child was playing a high strategy, high risk online game with his friends and was losing, so it wasn't the best time to try and do a blood pressure and pulse monitoring, and when that was repeated in different circumstances, it was completely normal. Sometimes a face-to-face examination may be necessary if a family isn't able to do home monitoring or if there's concerns about readings, but again, individual risks need to be considered, particularly if the family is shielding. And then very quickly, we've also put up guidance in terms of what to consider if you wish to initiate ADHD medication remotely, again based on the European ADHD Guidance Group. There are 3 conditions. I'm not going to go into them in detail, but the first 2 conditions do concern thinking about cardiac issues and if there are concerns whether a referral to cardiologist might be necessary. The third condition is that baseline monitoring should be done before initiation in terms of blood pressure and heart rates, and this should be measured by the carer remotely on 3 occasions. If it's not possible to do this, again, we need to think about the risk benefits of prescribing in a face-to-face assessment, and all that depends on context and severity. And quickly moving on to another area which is of great concern to many of our clinicians, and that's eating disorders. And as we know, children and young people with eating disorders are particularly at risk of contracting infection due to their malnutrition and potential lower rates of immunity. So this is a screenshot of some of the information we've got on our website, so please do have a look in more detail. I've just put up here a few considerations that we have discussed on our website. So firstly, need to think about the risks of COVID in this vulnerable population, as I've just described, and we talk about a number of circumstances when families might want to consider shielding the young person. For example, if the body mass index is under the 5th centile. We need to remember that the diagnosis might be difficult in this vulnerable population and presentations might be atypical. For example, there might be a lack of fever. This condition does place a lot of strains on young people and their families, and particularly at this time, we know that children and young people with eating disorders are very anxious in normal circumstances. However, with the virus, this anxiety is likely to be intensified all the more, particularly thinking about the academic impact of the virus and their worries about their futures and disruption of safe routines through isolation. There are particular remote treatment considerations in young people with eating disorders, and particularly around weighing. Some families might be able to assist with this, other families may need additional help through video consultations, and clinicians will need to think about specific care plans around this, and in some circumstances face-to-face weighing might be required, but again, individual risk assessments need to be done with regards to this. We do discuss the risk of inpatient care. There are always risks to inpatient admission, and of course that's all the more during this pandemic period, and infection control is absolutely paramount. One thing that we talk about in terms of inpatient admission is nasogastric feeding. There has been some debate about the level of PPE. We have said that if there is any risk that the patient is COVID positive, full PPE is advised for nasogastric feeding. And lastly, we've also got a lot of information for patients and carers, so please do have a look at our website. The most important message that we want to convey is that mental health services are still running and families should be coming to seek support, and referrals should still be making those referrals. And my very last slide, I just want to let you know about the Royal College survey that's happening on a fortnightly basis. The last survey was 2 weeks ago. We had 1,300 psychiatrists respond. And what we found was that 43% of psychiatrists have seen an increase in their urgent and emergency caseload, slightly less for child psychiatrists, and 45% have seen a reduction in their most routine appointments. And the biggest drop-offs have been in particular groups, which includes children and young people. So again, it's so important that we can get the message out there that children, young people and families shouldn't be suffering in isolation. They should be making contact with services because we are still out there, and it's so important that happens. And the last point I'd just like to make, that this pandemic has had a huge impact on our population, but particularly in terms of our vulnerable children, young people, and those with pre-existing mental health conditions. So it's so important that we get accurate data and research into the impact of this pandemic so that we can plan for service needs appropriately in the future, because we are concerned demand is likely to soar. And particularly in terms of thinking of young people going back to school, some children, young people are going to really struggle with this, so it's so important that they do have the right support in place when they return. Thank you very much. And I'd just like to bring your attention to minded.org.uk as well, which is hosted by the Royal College of Psychiatrists and also has lots of very helpful information for professionals and for families. Hello. Thank you. I'd like to introduce Sally Powis now, who's a consultant clinical psychologist and clinical lead for Helios.
Hello. So if we can go to my first slide, please. Thank you. So I'm Sally Powis. I'm a clinical psychologist, and one of my roles is as clinical lead for the autism pathway at Helios. Next slide, please. So for those of you who are not familiar with Helios, we're an online provider of mental health services, primarily to children and young people and families, but also to adults and some of our pathways. And the organisation has been delivering online therapy and assessment sessions for, I guess, about 7 years now. So we've had quite a lot of time to learn and to improve. Next slide, please. So I've been involved myself for about 3 years with Helios, and even in that time they've grown rapidly, and so we've had to learn and adapt as we've gone along. We now work with about 50%, I guess, of NHS trusts in the UK. Next slide, please. So this is just some of the various ways, I guess, that we've had, that we've received feedback about what works and what doesn't work in the sessions that we've been doing. And interestingly, a lot of what Peter and Marco and Gavin have all said earlier has been our experiences in what's worked and what hasn't. So we last year held a focus group with some of our clinicians to help understand what their experiences were, because we were interested in making that comparison amongst clinicians who were working online, but also working face to face, mostly in the NHS. Most of our clinicians are either part-time with us, part-time NHS, or they're left the NHS and they're now working with us. So next slide, please. So these are some of the feedback themes we had. So no surprise, most clinicians like the ease of working from home, the comfort, the lack of stress in not having to travel, of fitting it around families. We're very fortunate really that we have one platform that was developed specifically for this. So it means that all the information that clinicians need, the referral information, the session recordings, because every session is routinely recorded, they're all there in one place for them. So that was another bonus. People felt that, interestingly, multidisciplinary working was easier to organise. Getting people together online for an MDT, for a case discussion, was much easier than their experiences of doing that face-to-face, getting everyone in one room. And also the ease of having all the background information, referral information, outcome measures, everything you need in one place, working for your sessions to make those more straightforward, was successful. Okay, next slide, please. So again, for us, we've been able to digitalise and upload assessment and therapy tools to recognise ones that clinicians use in their face-to-face work so that they're familiar with those. That's been helpful. A kind of unexpected bonus, which could be seen either way, is that using pets and using toys to break the ice as icebreakers to help engage with children has actually been really successful. So clinicians who've had dogs, where dogs have been in the room, or they've been able to bring them in deliberately to talk to children about them, that has made things very helpful at times. It's kind of, as I say, broken ice, help with nervous children. Also children who might find it difficult to engage in the normal process in a room. So a clinician last week in supervision was talking about having seen a child who, while she talked to the parent, because the child was reluctant to come on screen, she started off by getting one eye, and then she got a nose, and then she got two eyes and a whole face as the child kind of edged into camera view and was then willing to sit down and to talk. So it gives you a bit of flexibility, I guess, in how you might use those situations or work with those situations. Personally, I have a client in therapy who is selective mute, and with him, we started with his camera off, his microphone off, me talking, we're both typing, he's typing on the chat side, and then we've worked towards him switching his microphone on but keeping his camera off, and then the next step will be him putting his camera on. So it gives you a possibility to kind of desensitize in that way to acclimatizing to a therapy session with somebody who might not be able to manage to do it in a different way. Next slide, please. So this is feedback we've had then from families when we've asked how they're finding online sessions. Generally, it seems that our experience has been that the children engage really well. And I guess this is a generation of children, young people, for whom being online is almost second nature, probably almost more so than their parents. So the fact that the child can be in their relaxed space when you have a child who's very anxious, that has helped. We've had quite a few parents say they would never have got the child out the door and actually to a therapy session somewhere in a clinic, but the fact they've been at home has meant that they have been able to do that. Some of the things mentioned earlier, the obvious things like the convenience of appointments for parents. So we've had parents who will say they like the fact that they've been able to log on, say at lunchtime from work. And we know that pre-COVID, obviously this is, that some schools have been willing to find a quiet space for a child to use a PC and log on while they're at school, so that sessions can take place then. And equally, it's meant not so much ferrying around after school to get children to sessions. So that's been, from parents' point of view, that's been something they've been grateful for. And as mentioned earlier, no surprise that if you have parents who are separated, or one parent is working away or is abroad, everyone can join the sessions remotely from where they are geographically. So I have a regular session where dad's in Slovenia and the young person is in Cambridge, but we all join online, and that seems to work well. Next slide, please. So one of the things that's been valuable learning for us is that it's not just actually been about the online session. So much as presenters have been saying earlier, it's about having all the backup and support around that makes it work for the clinicians and for the families and for the children. So early days when we were running, we lost some clinicians due to frustrations around this kind of, when we didn't have all our systems in place of the backup support. So it's about clinicians being able to get the right tools when they need them in a session, being able to find it easily, down to basics like ensuring that children and family can log on okay, and that from clinician point of view they have quick and easy access to the tech team. If it's not working, what do I do? Who's going to help? And reminders going out to families to attend, so that they know when their session is, they know how to log on, they know how it all works. It's going to be interesting, as was said earlier, see how lockdown has affected this, with a lot more people now becoming more used to using video chatting and video talking. Yeah, we'll see whether it makes this easier for people. We routinely record sessions. They're all recorded securely onto the platform. That's been a real positive and really helpful. It allows us to use them in supervision and to review them in MDT sessions if we need to. And I'd say early days we had some hiccups as well with enabling the routine outcome measures online, which we've, for us, fortunately, we're now able to digitalise and automate. So again, for clinicians' point of view, being able to find the tools they need to do their work whilst they're working in a kind of timely manner and an easy manner has been really important. Next slide, please. The other reason we lost clinicians in the early days, interestingly, was due to feelings of isolation on their part and detachment. So this was an article I read about 18 months ago in a business part of the paper talking about purely online companies often having a much lower retention rate of staff because staff don't feel as connected with the organisation. They don't feel a part of a team as much. They don't have the same level of loyalty. It's much easier to just send an email resigning. Whereas if you have that face-to-face relationship with people, you feel much more included. So we started introducing things like we have a 10-minute coffee and catch up every morning. It's not obligatory. If you want to, you can check in, you can see who's there, you can have a chat. We have brought in Slack. So we use Slack as an instant online messaging communication tool, not just for work stuff and for instantly getting hold of the tech team, but also we have like a random channel for clinicians just to get to know each other. There's a lot of photographs of dogs and people's interests up there, but it all helps promote that sense of being part of a team and part of working together in the interests of your clients, and therefore that has meant that for us our staff retention has been much better. We now have a strong sense of teams working together. Next slide, please. So I guess the considerations, the adaptations, a lot of which have been mentioned earlier, have been things that we've learned as we've gone along, a bit by trial and error, really. So it does require more focus and attention working online. Being in a room with a person, it's much easier. You have a sense of presence. You're much more engaged with them. So you have to use your active listening skills a lot more when you're online. You have to be nodding and letting know that the person that you're still here. Personally, I have a client where if I don't move or say something fairly regularly, he becomes really scared that the screen has frozen, and then he gets very agitated and very frustrated. It's also less, your attention is not grabbed as much by seeing somebody in a small screen online, so it's much easier for you to be distracted, the clinician to be distracted by somebody walking past the window. Is happening outside my window at the moment with the gardening. There's stuff going on, so you're working more intensely when you're working online, we've discovered. That means that it is more tiring. And actually, tempting as it is to pack in lots of online sessions in a day because it looks like it's easier and you can do that, actually people burn out. And we've learned that you have to balance the online stuff with the other clinical work to make the working week manageable for people. I think, as mentioned earlier as well, you have to compensate for the less obvious body language that you can't necessarily see. So it's important to set up, as was being mentioned, it's important to set up your sessions correctly so you can see enough. You can only just see a part of me, but we usually ask to be able to see the top half of the person so you can see more non-verbal communication than you might otherwise. And you have to compensate verbally for that at times by asking, where are you looking? Because people will usually tell you if they're looking at themselves, and what can you see, or what are you doing? So last point, I guess, that obviously obvious and stated earlier, good internet connection is key, and not everybody has that, and not everybody has really good up-to-date devices which help them work. So we learned, again, reasonably as we went along, that whereas smartphones are acceptable for some sessions, for other sessions the client themselves needs to have a much bigger screen so that you can see more of them and you can see them in more detail. I think that's mostly it from us, from our learning. I whizzed through. I think it's not, as being said here before, it's not necessarily a question of either or from us. Both have their pros and both have their cons. Obviously, in lockdown at the moment, we don't have a choice. But for many people, they prefer online working. They've found it much easier, and for others, it doesn't work. And I guess it's just being aware of that. OK, and that's us. Thank you. We're now going to hear from young minds, I believe, about their experiences.
Hi, my name's Lauren. I've been a youth advisor on Amplified for the past 4 years, and I'm just going to talk to you a little bit about participation and what it means to young people. Participation, by definition, is the action of taking part in something, but for young people, participation can mean a whole lot more. It can be life-changing. I know that sounds kind of crazy, a little over the top, and perhaps even like I'm trying to oversell it, but from my own experience and hundreds of other young people around me, it is so true. Aged 11, I joined a youth group, Trafford Youth Cabinet, a group part of a larger UK network that make up the Youth Parliament. This group was my first ever experience of youth voice or participation, an introduction into a world that would soon define my teenage years. I quickly found that there was an incredible community of young people out there working hard to be listened to have a voice and to participate. From climate change to mental health and girls' rights, I quickly became aware of this new world. And as I got more and more passionate, my involvement grew. I went from a quiet little girl to someone with strong opinions who would find the platform to share them. I became that person that wouldn't sit down and watch if she thought something was unfair and unjust, but instead stood up and tried to change it. And in times when things got tough and do get tough in life, youth voice and participation was always there to lift me out of the darkness. This was particularly true when it came to my own struggles with mental health. Youth voice work has given me all the skills you may expect it to: confidence, public speaking skills, organisation and leadership. But more than this, it's given me a sense of belonging and value, a family. It became a place that no matter what was going on in my little bubble, I could go and be who I wanted to be. I could go and make friendships that would last a lifetime and stand up for what I believed in. It was more than a safe space, but a place where I was constantly supported and encouraged to push boundaries and be the change I wanted to see in the world. And I'm not the only young person who felt this way. For young people, participation can provide a sense of control in a situation where a lot of control feels taken away. That's particularly true when it comes to mental health. I've watched numerous frustrated parents and young people wanting to have their say in their care and support, but unable to. I've also seen the incredibly positive impact that those who are able to participate can have, and I've seen some incredible examples of services and young people working together. In a situation where we cannot control what will happen next week, it is especially relevant. We've all spent the last 7 weeks trying to get used to this new normal, a normal where everything we knew and did has changed, and for those suffering with their mental health, this is even more scary. Their support and how they access this has changed. More often than not, they are left feeling more alone and isolated. But participation, even remote, can change that. I've seen so many youth services step up, throw away that 5-year online action plan and transport it into the here and now. It hasn't been easy and lots of learning has taken place, but it is possible. So how can you do it? I don't think there's a plan or guidelines that will work universally for services. Each and every service and their need is a little different. But here are 5 top tips in order to create some online participation with young people. Ask young people. Chances are one of them will have a unique idea that you hadn't even thought of. 2. Don't be afraid to get it wrong. Unless you're willing to have that failed Zoom call with 2 people that goes terribly wrong, you won't find the right way to do things. 3. Use platforms that young people are already using. Instead of creating new platforms or new software, use things young people are already using to stay connected in these times, whether that be a poll on Twitter or an online Zoom call. 4. Be creative. We all know that internal sigh when we get sent yet another survey. Be creative in your approach and remember that this is more than just a tick box exercise. And finally, ask for help. Over the past 7 weeks, I've seen numerous youth services and charities do incredible online participation with young people. There's been so much learning and sharing. Don't be afraid to reach out and use this. It won't be easy and you will make mistakes, but without the learning and the mistakes, the best outcomes wouldn't be possible. Now isn't the time to shy away from participation. Now is the time to connect with young people, to give young people a voice, because after all, we are the
I'm George, I'm a Young Minds Youth Advisor on the Amplified programme. I'm also a Young Minds activist. Today we'll be talking through the survey responses from the Young Minds app. So a bit of the survey background. The survey was of 10 young people on their experience of accessing CAMS in a remote setting. It was open for 1 week on the app, so the turnaround was quite fast, and a small sample size means that the results aren't truly representative. However, you will notice some common themes, and we'll run through those through this presentation. So 100% of the respondents were receiving face-to-face support prior to COVID-19. 80% of those sponsored have had a remote mental health appointment by phone, video call or text at some point during the lockdown. And since COVID-19, 63% of the respondents have switched to remote support and 37% have not been able to access it. When we asked whether the offer of remote support has been helpful, this was the response. We got it in the pie chart here. So 45% actually said no, it wasn't helpful, which is quite a high number. And 33% it was better than no support, and 22% said yes, that positively helped them. These are the reasons why it hasn't helped people. So one of the biggest things is on the why not was the phone calls. A lot of people struggle with the phone calls and find it was almost too impersonal because it's not face-to-face contact. But on the positive side, people are grateful that they can still access support and have the option there to be able to call or phone or get into it at a difficult time. So when we asked the respondents how the experience of remote mental health support services compared to face-to-face support, 37% said their experiences has remained the same, and 63% has said it has actually worsened their experience of mental health services. So how can clinicians and services improve the support they provide remotely during COVID-19? One of the biggest and most recurring theme was a live chat text messaging service. So having that 24/7 kind of instant support, whether you can just drop a text or being able to chat with someone in a chat box and say, this is what I'm going through, that was one of the biggest things. Giving activity or worksheets related to the session prior to the call, so the young people know what they're about to experience and having it beforehand. And offering different forms of contact communication, email, text, and then scheduling the call times. One of the big things was having unplanned and out of the blue phone calls, which contributed to some anxieties. So kind of scheduling those call times, and then muted phone conversations. So having the video of the person on the screen, but it's just a chat box instead of actually speaking, so no one in the house can hear at the same time. So the information we asked what young people would like to receive before they access the support. Again, there was some overwhelming sort of themes here, and the first one was understanding of what the support will involve and be like beforehand. So knowing what they're about to discover, knowing what they're about to have and get support with was one of the biggest things, and the frequency of duration of support, knowing how long it will go on for, knowing how long the session will last, and knowing how long they'll get those sessions for, but also a clear understanding of that communication and how confidentiality works. Obviously, if they're in a house with family members, how does confidentiality work about talking some sensitive subjects, and then knowing different options before and a potential assessment to help decide what support they need and how they can access it, whether that be via phone, email or text. So when we asked young people what they would recommend clinicians and services not do when providing remote support, one of the biggest things, and this was from almost everyone that sort of sent in their answers, was assuming everyone's house situation is the same. So if you speak to one person and their house situation is that, assuming the next person can also have the same situation, and just not knowing if their home situation is safe or if they have a safe space to talk about what they're going through in sensitive subjects was one of the biggest things. Again, unplanned phone calls, and then discriminating against people who struggle with phone calls. Obviously, it's very hard if you can't have a phone call with a young person to be able to talk about what they're going through, but thinking about alternatives at the same time, and then saying you'll be okay and not listening to their true feelings. Hearing them out, talking about what they're going through, but listening to what they're really saying, and avoid focusing on the lockdown. Think about what the person's mental health was before all of this happened. The lockdown may have, yes, contributed to what they were going through, but focus on what they were experiencing beforehand, so then tackle that. So how can clinicians and services best support young people when we're transitioning out of lockdown? The first thing is understanding the transition period can and will take time for some people, probably almost everyone. So it's going to be a very odd situation when we are transitioning out of lockdown. Obviously, it's going to be quite a long period and it will be back in, back out. So kind of recognizing that will take a bit of time and being sympathetic with it. And then reviews to gauge people's mental health changes during the lockdown. So kind of having a gauge or an idea of what's happening with that young person while coming in and going out of lockdown. And we got the response of a drop-in appointment option via phone, email, face-to-face, scheduled calls, texts. So if that person is feeling okay or not feeling okay, they can then drop in or drop a text and get a response that way if they don't feel comfortable having the face-to-face contact. But also recognizing that it's obviously a very traumatic experience, it's a very surreal experience, and a lot of people haven't had this experience before. So understanding and kind of encouraging that it's absolutely okay to feel the way they do, and then encouraging again that gradual step towards transitioning back to face-to-face support whenever they feel ready, and helping with that. So it's obviously been a recorded presentation, so we can't take live questions, but if you do have any questions, you can send them to the webinar host.
And thank you so much, Nathan and Young Minds. And I'd just now like to roll us on into the roller coaster presentation from Wendy Minanet and Nikki Harmer. And this is also a pre-recorded video presentation. Thank you, Rachel.
Hi everybody, I'm Wendy Minanet from Roller Coaster Family Support.
Hi, I'm Nikki Harmer, Team Manager within CAMS within the Tees Esconway Valley NHS Trust.
And today we're just going to share with you a little bit of our learning from the last few weeks where we've offered digital support to parents during COVID.
So what we wanted to do is let you know what we did before. So before COVID, we ran face-to-face support groups 2 a month. We did advisory work, digital support and training. And we're really fortunate because all of this has been commissioned by our local CCG.
So when we got news of lockdown, we knew that we had to do something different. We had to do something new. So we got brave, and so far we have run 5 Facebook Live groups, 4 Zoom support groups, and a number of different training and information sessions. How we did that, in terms of Facebook Live, we were able to go live straight into our existing closed social media group. In terms of Zoom, this was something brand new, and it was something parents asked for. They said, can you run Zoom support groups? So we said, let's give it a go. We ran some of them at the same time as our existing face-to-face groups. We wanted to make sure that there was some familiar things, so we set around us with chocolate and cuppas and all the things that we know that people are used to when they come to our face-to-face groups. We set a virtual ethos that was to help keep people safe and know what to expect, and to keep the session structured, we set an agenda. In terms of engagement in Facebook Live, we had quite a lot of people who engaged in the sessions directly at the time, able to talk on the chat box function and see us live. But what really surprised us was the number of people who actually engaged in sessions afterwards, so they could go watch what had happened, catch up and continue to comment on some of the sessions. And that's been something that's just been amazing, because we've never been able to offer that before, offering support outside of the time that you would run the sessions.
So by using Zoom, it was totally different. So Zoom was much more engagement and interaction. We're able to engage directly with parents and carers the same way as if we're in a face-to-face support group. So we've done interactive activities with a virtual flip chart, shared positive quotes, and always ended with a sing-along, which has really, really been positive.
It hasn't always gone plain sailing. Things have gone wrong. This was a session where we thought we were going to be really clever and zoom into Facebook Live. It didn't quite happen that way, and we actually ended up having a Zoom on the go and a Facebook Live at the same time. We got off the session and thought, that was just awful. And then we got the feedback from people, and actually it wasn't awful, and people learned along with us. They had a giggle, and I'll just pick out a quote there, because there was somebody who'd only just joined the day before, and that session, as eventful as it was, helped them feel supportive. So even when it goes wrong, we can be making a difference. Just to pick out a couple of quotes, we're getting lots of good feedback. Parents are telling us things like it's uplifting at a hard time, it's good to interact, good to just see another adult face and be able to get some advice and tips.
Yeah, people are saying that they're still thankful that we got roller coaster, because it's getting us through getting through this time. And also what I said before, so they watched after the event and really enjoyed the group. So again, how much positive that can make. So one of the things before COVID is that we always captured the themes, and we've continued to do this in a virtual group. We've been able to use these themes to inform practice, change, and deliver training.
Yeah, and I think another really important point to pick up here is the peer support that's happened. We've been able to observe and see that more than ever before, where one person's come in with a particular issue and somebody else has got an idea, a response, or something that they can try, and it's been lovely to capture all of that in the digital learning. In response to some of those issues, we've been able to set up training sessions, either in partnership with one of the CAMS clinicians or in partnership with another organisation, and they've really proven to be successful with families, people feeling that they're getting more advice and information to be able to support their child at home.
One of the big things is that we've always done roller coaster in partnership, always since the beginning. So we wanted to continue that with the virtual groups. And being able to do that, I've been able to offer communication, live and regular updates about what's happening in CAMS at this time on this digital platform, advice and guidance, and containment and reassurance from our families from a mental health point of view, what they can do to make things okay at this time, and increased access support. So while we've been on the Zoom or Facebook sessions, I've been able to email families directly with parent referral forms, guided self-help.
And parents have really appreciated being able to ask a CAMS clinician those questions directly, particularly in the early days, Nikki, when people were like, is CAMS still open? Can we still have our appointments? All that kind of thing. So it's been really beneficial.
So part of when we did face-to-face meetings, it was very time consuming from a CAMS clinician. We'd have to take half a day out in order to do the meetings. Now, I would often ask clinicians to come along and present at meetings, but it was time consuming in their diaries. By doing it virtually, we've actually been able to increase clinicians' time on the Facebook group, bring their expertise, and as you can see, the feedback's been fantastic.
Loads of positives from what we've done. We're so pleased that we have done it. I just want to pick out a couple of things, and I think the biggest thing that jumps out to me, I've already mentioned it, is the peer support that you're able to see happening live in those sessions. It's enabled people to, connect, to feel empowered, and to have hope during this really, really difficult time. And something that we would never have got from the face-to-face groups is people accessing a support group anonymously, so people can be on the Facebook Live and you don't know that they're on. And even with the Zoom, for all it's not anonymous completely, people don't have to put the name on, they don't have to put the camera on, they can just be there and listen, and that's been a really good part of the positives.
With all technology, there's always negatives, and absolutely facilitator fatigue, talking constantly at our video screens, technical difficulties, but absolutely we've powered through. It's absolutely not for everybody, and some people totally recognise that. It's been much more demanding on Wendy's time, I must admit, but also for them families that have been unable to access digital, whether that's due to cost, whether that's due to connection. So we really need to look at that.
In terms of our next steps, we're still learning. It will absolutely be part of our parent support offer moving forward. We'll move from we'll be offering weekly sessions going forward. That will allow us to increase support, engage new people, and I think ultimately, if I could sum it up, it's about offering choice to people. And one of the parents, that quote there, said that it's like having support in the pocket, and I think that's something amazing that we can bring with digital support. They might not always access it, but they're not there when they need it. And part of that, and thinking about the digital support offer moving forward, we've got to help increase people's confidence to access digital. A lot of people, just like we were, what's Zoom? Never heard of it. How do you do it? And we need to think about how can we help people access, so maybe it will be for them, even if they think it's not at this moment in time. There's huge potential to offer partnership sessions and to be able to do things at scale with other organisations. And I just want to mention very briefly again what digital technology has allowed us to do in the last few weeks is bring together a range of parent support projects or people who are interested in parent support around the country. And we're going to be working together to think about what can we offer digitally that we don't have to all, reinvent and repeat in every area, we can come together on this. So if anybody's interested in getting involved with that, get in touch with us. And just to sum up, I guess those 7 points there are from a parent who said, this is what digital support is giving me. We haven't got time to go through them all, but when you look back at this presentation, that sums it up. It can make a difference in a way that we have never thought of before. So what we would say from both of us who were scared stiff to do it, but knew that if we wanted to continue to reach people, we had to give it a go, is go for it, give it a try. Get in touch with us if you've got any questions or queries about anything. But yeah, digital support is definitely part of the future.
Thank you very much. Any problems, any concerns, any questions, just give us a contact. We're always open to that. Thank you.
And thank you so much, Wendy and Nikki. And we've been running slightly over, so we've got 5 minutes left before we conclude, as we've promised. Alex, I may call you in, and thank you, Alex, who's been the behind-the-scenes maestro for this, along with other members of our sort of business support team. If you can chip in a short while to explain what some of our next steps are going to be. But before I move on, I'd just like to sort of very much thank all our presenters today, and especially the few of you who've wrestled with the IT almost inevitably, and also some of our attenders who've not been able to log on or who have struggled to actually log on. We'll try and do some work to understand what those challenges are and resolve them for any future webinars, which is very much what I'd like to just come on to. So this is sort of an introductory double session, and what we've been planning is an initial series of 4 further probably 60-minute topic focused webinars, probably at fortnightly intervals. And I caveat some of this because we'd very much like to get your feedback about it. These ongoing sessions will be aimed at practitioners who are already familiar with undertaking the face-to-face or in-person work in that particular topic area. So, for example, CBT with anxiety and depression. So the sessions are aimed at helping us all to learn about, as we heard from Sally, and transfer our existing skills to remote working practice, where and how that's appropriate. Although I'm also looking forward to some really wonderful revision as well. Our thinking is to structure these sessions in the following way. Firstly, looking at theoretical and empirical evidence. And then secondly, where it's appropriate, where there's any legal or professional or policy guidance that's impacting on that particular service area. Thirdly, to look at clinical practice and learning, so hearing from folk who've actually been doing that particular work. And then lastly, but not at all lastly in my mind, is what observations and learning can we take from service users' experience, from children and young people, and also parents and carers. So just thinking briefly about that initial topic list, and I'm hoping, Alex, that we can post this on the NHS Futures collaboration platform and also send it out in an email perhaps to communicate with you guys out there. So the initial topic list we're thinking about is working with anxiety and depression, working with challenging issues such as self-harm and risk assessment, which we heard a little bit about from Banadka. And then thirdly, looking at apps. We've got many new apps sort of joining this space at the moment, but also some more established apps, some of whom are freestanding, others like Blue Ice, looking at suicide prevention, are sort of clinician joint projects or clinician referred. And then fourthly, working with trauma and with PTSD. Our thinking currently is that the first follow-up session will take place in 3 to 4 weeks' time, and we're suggesting at the moment that this will be on a regular slot at fortnightly intervals, probably Wednesday or Thursday. This particular slot we're in now actually clashes with the IAPT practitioner webinar, so we want to avoid that, particularly for a few of you who want to join both those sessions. probably first thing or around about midday, but again, any feedback, very welcome for that. So comments and suggestions for later sessions and also speakers, very welcome indeed. So we'll just where I'd like to end up before actually asking Alex if he's got any sort of final contributions and comments about this, is we'll be posting both the webinar itself and also the FAQs that people have put in and we've put replies to on the NHS Futures collaboration platform, and also I think on the WeTransfer link as well. So Alex, if I can just pull you in, is there anything else that you want to add to that sort of next steps and housekeeping?
No, thank you, Steve. I think you've covered everything. I think it's worth observing that at the peak we had 513 attendees dialed in, which is great for the first call. So thanks to everyone who has taken some time out of their day to join us. We've really enjoyed it and we're looking forward to the next ones.
Yep, very much looking forward to the next ones, Alex, and everybody. One of the things that we will experiment, I think is probably the best thing to say, in our next session is whether we can actually, we know we can conduct a survey through MS Teams, and we'll experiment with doing that so we can get some sort of direct feedback from you. So thank you very much. Thank you to all the 500 people who dialed in. Thank you so much to all our presenters. Thank you to the behind the scenes team who've been working exceedingly hard, not just now, but over the last few weeks as well, to prepare this. And apologies to those people who weren't able to join us today, despite, I know, for some of you, many attempts. So thank you very much. Goodbye, and I look forward to seeing you in a couple of weeks' time.